Well, good morning, everyone. This is Kate O'Malley with the California Healthcare Foundation. Thank you very much for joining our webinar today to learn more about the request for proposals that we have issued around health insurers and payers and palliative care providers in new models of care. We are recording this webinar, and we have 50 people now registered on the teleconference, which is very exciting. Thank you all for taking the time to be with us today. We estimate that this call, depending on your questions, of course, will take about an hour, even though we've set aside a little bit more time than that. So if we're wrapping up a little bit early, then that is fine, and happy to spend this hour with you. So to get us started, I just want to talk a little bit about what we want to happen today on the call. We want to introduce the initiative to you, really basically following the outline that's in the request for proposal, and then answer your questions, and then talk to you a little bit about some resources that might be helpful for you during the process of preparing the application or the response to the request for proposal. Just a little bit about the California Healthcare Foundation. We are a foundation based in Oakland, California, and we work as a catalyst to fulfill the promise of better health care for all Californians. This particular project is being sponsored by the Better Chronic Disease Care Program area, of which I am a member. And in this work, we seek to improve clinical outcomes and quality of life for Californians with chronic disease. So a little bit about the initiative. There's a lot of threads that have actually come together to inform the development of this initiative and really give us a signal at the foundation that the time might be right to launch such an initiative here in California. I'll think back a little bit to the Let's Get Healthy California initiative, a report that was published the end of December in, gosh, it was 2012, I guess, which really identified end-of-life care as a very important component of healthcare for Californians. And this initiative was led by Secretary Diana Dooley in the Department of Health and Human Services in the state of California. And from that, from the legacy and the direction that was created in that document, many of the ideas and the hopes and the approaches related to palliative care were incorporated into California's state innovation model, which is seeking funding from the federal government through the Medicare program to pilot test and to test some models, including palliative care services in California. And additionally, on the national landscape, you may know of lots of areas of interest related to palliative care, particularly in the community settings, and more evidence coming out about the benefits of palliative care for people with serious illness. So as the foundation looked around for ideas that we could continue to promote and sponsor, we thought the time was right to really look at increasing access to palliative care in community settings by stimulating partnerships between payers and palliative care providers to really bridge the gap that I know on the provider end we see so commonly, the interest in fielding an interdisciplinary team and struggling with the difficulty of finding the payment to really achieve the promise of palliative care for people with advanced illness. So about this initiative, based on the historical interest in the state and the growing evidence nationally about the value, we really want to promote partnerships between health insurers or payers and palliative care providers, including hospice providers. And through this initiative, test the mechanisms to enhance access to community-based palliative care through novel delivery and reimbursement structures. And by novel, we mean things that we haven't seen before in California, which may be present in other states, and we want to test and try here. We would award up to 10 planning grants of up to $50,000 per partnership. And from this experience, the foundation would consider implementation grants in 2015 based on the success of the planning grants. So who can apply? We're really looking for partners to come together. So people would apply, or the application would be a combination of two distinct organizations. And each partnership would include a California delivery organization and a payer or other organization that bears risk. The partnership may be new or an existing partnership. And by an existing partnership, I'm thinking about a palliative care provider that's already thinking and working with a payer to increase access to community-based palliative care and may look at this opportunity as a way to stimulate new thinking, to focus new resources, or to bring new aspects of the work into something that's currently happening that really focuses on community-based palliative care. And there may be some payers out there and providers who are already working together in other areas and want to expand to community-based palliative care as well. The organizations may be for-profit or not-for-profit. And the providers who come in through the request for proposal must currently offer community-based palliative care. And by that, we're really looking at an organized service that sees patients, identifies needs, makes treatment recommendations, facilitates patient and or family decision-making, and directly provides palliative care to patients with serious illness and their families. So most palliative care is provided by interdisciplinary teams of specially trained healthcare professionals working together to address patients' physical, emotional, social, and spiritual needs. And we feel it might be helpful to really call out what we mean by community-based palliative care. Those of you in the field may know from your own experience that palliative care flies under many flags. And some people who have social work, nutrition support, let's say, for example, for patients with cancer, might think that that's their palliative care team. So for this particular process, we are looking for providers currently offering an interdisciplinary team of palliative care services in a community setting. And we're thinking that this can be provided by hospices, health systems, hospitals, medical groups, home health agencies, or social services organizations. You may be interested to know that the foundation is currently involved in a mapping exercise in California, trying to find locations where palliative care is being delivered in the community. And although these findings are not ready yet, we're still verifying the data and seeking as much data as we can find and encouraging people to respond to surveys that we're sending out looking for palliative care. We've identified up to 150 locations in California where community-based palliative care is being delivered. So we're excited. We know there's a lot out there, and we hope we'll be hearing from you through this initiative. So what we're looking for, what's going to come about if you participate, if you submit a request for proposal and are selected to participate. Grantees under this initiative will develop an operational and financial plan for delivering palliative care. And it would include a description of your partnership. So you've come together with a payer and a provider. What does that look like? What palliative care model are you proposing to implement in your area? So what setting, what staffing configuration, how are you identifying your target population, other things related to how the services will be delivered. A sense of your workforce capacity and development needs and your plans. A pricing and payment mechanisms for the services that are provided. A sense that you've thought through the potential challenges of doing this kind of work, and also a plan to monitor how it's implemented and how you would determine organizationally whether or not this was a success. Some of the logistics on the proposals will indicate the lead organization to receive and to manage the grant funds. So the foundation is interested in just knowing one lead person that would be responsible for the reporting and the budgeting and the accounting for the funds that are provided. Grantees will attend an in-person meeting October 20th and participate in mid-course check-in. And this meeting on October 20th will be held in Huntington Beach. It will be co-located with the annual meeting of the California Association of Health Plans in Huntington Beach. And as we get our grantees assembled, we would obviously provide more logistical information about that. But it would be an opportunity for the provider-payer teams to get together as a cohort and really we would help you with learning, and you could meet each other and share your own information in a small learning community at that time. So the proposals that are due August 8th from this work, we will be reading, reviewing, scoring, and determining who receives a grant, and that would be notification on September 5th. Then from there to October 1st would be the contracting period. The grant would start October 1st and run until March 31st. And as I mentioned, our grantees would get together on the 20th of October. And then the final grantee reports would be due on March 31st. So the Grantee Resources, the foundation would provide funding up to $50,000 per partnership. And the intention of providing that funding is to buy or allocate some dedicated time from each partner organization to really focus on the planning grants. So it could buy some time from knowledgeable staff within your organizations. You could use the money to buy some consulting time who could really help you focus on how you would get the deliverables together for this project, but also really to help yourselves understand better that landscape and how you would want to create an implementation plan. We would provide technical assistance related to clinical strategies. We will be working with our colleagues at the Palliative Care Leadership Center at UCSF, who operate community-based palliative care services themselves and are very knowledgeable on the national scene about what's happening, where the good examples of clinical models, what can we learn from related to what other people are doing. We would also provide financial modeling, support, and consultation with Kathleen Kerr, who has done a lot of work in California in community-based palliative care programs, really looking for the impact of palliative care and then the cost of providing such palliative care to come up with a calculation of return on investment. We also have Nancy Wise from HTMS, a consulting group, and she is an expert in insurance areas. For the group, once it's assembled, we would be providing this assistance in person at the October meeting and also through webinars and telephone consultations, and other ideas may occur to us about ways we can be supportive that we haven't really identified yet, but will once we have the applications and have had a chance to meet with the group that we'll be working together with in the planning grant process. We also have project management available with Kate Myers, who is a project manager who's recently been working with the foundation on with 21 organizations statewide to really look at what are they doing, what are we doing, what's being accomplished in California around community-based care, and has lots of information about clinical programs and staffing, which we can make available to you. The other resource, a couple of other resources I really want to recommend that you explore and become very well acquainted with is the the Center to Advance Palliative Care in New York has published a toolkit, and the link to that toolkit is in the link at the end of this particular slide. This was a collaboration between the National Business Group on Health and CAPC, and was funded in part by the California Healthcare Foundation. And this is really a excellent resource that really talks about what payers and providers are doing nationally to really improve the care for people with serious illness through palliative care. It has excellent background materials, talks about different models. It really talks about the essential characteristics of high-value palliative care and the essential clinical skills, and provides really an action plan for payers that really talks about how to prepare and implement programs that address needs of people with serious illness in the community. So I highly recommend that this resource be scoured for ideas that resonate with you and appeal to you, and that you might make use of as you're thinking about how to plan to respond to the RFP and what you might do in the planning grant period. Another resource I will mention that is not available yet, but is being developed, is a field guide that harvests all of the learning from the work that we provided or that we did with our 21 community organizations that are providing palliative care in California. We have a lot of promising practices and a lot of examples of how people are organizing their services, how they are being reimbursed for their services. That will be ready in September, and that will also serve as a very important resource going forward. So the application process, all the details are included in the RFP, but for the sake of completeness, I will just mention them to you here. We're looking for email a single PDF to Glenda Paha, her address is there, by 5 p.m. on August 8th. We are an electronic organization, so you don't need to rush to the mailbox to get anything in the mail. Email is fine, and we will acknowledge receipt in a return email. The proposal packet should include a cover sheet, and all these details are available on the Foundation website. A proposal cover sheet, the tax ID information for the lead organization who will be handling the money, the proposal narrative, the budget, and the partnership lead qualifications. All of those things are described in detail in the RFP. And with that, I am ready for questions and comments, and we do have a chat box. And so we are seeing some questions come in on the chat box, which I will answer. And then I think we'll just open all the lines and see how it goes. You never know with these things if someone's put us on mute. But if that's not the case, and we can have everybody in, and if we can have everyone in, then we will open all the lines for verbal questions. One question is, I understand that the definition of community-based palliative care includes non-hospital settings. Would the SNF setting be part of this model? Interesting question. Yeah. If you have we understand that skilled nursing facilities are the community for the residents who live in them, so we'd be happy to see a proposal that looked at improving the SNF setting. So sure. Second question, how is CHCF defining payer in this RFP? Must it be health payer, Knox-Keene licensed entity? Are you assuming that the financial plan produced will include risk assumption for this population? Well, that's a very detailed question. It does not have to be a Knox-Keene licensed entity, so we're not considering only HMOs. If it is a risk-bearing medical group, for example, and they intend to enter into a partnership with an outside palliative care provider to expand their access or expand services available to the beneficiaries that we serve, we would consider that as well. Let's see, another question is, we are a nonprofit with 4 group homes that provide palliative care in Los Angeles. We are funded through HOPWA and HUD. HOPWA. How do we find a payer partner for this proposal? Well, that is an interesting question. One thing I would mention is that it's not the intention of the foundation to do matchmaking as part of this initiative. So to qualify, you have to come to us with a payer who's willing to work with you on this proposal. So if you know of the insurance coverage or the coverage for the people that you're serving, it's possible that you might approach them to see if they would like to be a payer with you. I'm not sure I know what HOPWA is. Any ideas? No. Okay. If you could chat that back in, maybe I would have a better answer related to that. Oh, here it is, Carol. Another question, does the payer have to be an insurance company, or can it be a partnership between a SNF and a hospital who is paying for the palliative care services? A hospital who is paying, they are the payer. I guess we need to know more in your application. If you're coming in If you're applying with a non-traditional payer, you would need to provide us enough information that would let us know how this entity is functioning as a payer. And maybe it would be helpful just for me to say a couple words about the intent of this work. So the intention, or what we're striving to get at, is to stimulate partnerships between payer communities and provider organizations that might not already exist, that could come up with replicable types of models or expanded types of models that would provide a revenue base for community-based palliative care to be provided. So that's the intention of this work. And, you know, if as you are developing your approaches prior to the deadline for submission, if you want to send me an email with a specific question about what you've lined up and whether or not that would qualify, my email address is also in the RFP, and I would be happy. I've already answered a couple questions from people before this call related to who qualifies. So we're trying to make this broad, but also meet the intent of the initiative, which is to come up with replicable models that can be adopted and spread in California. Here's another question. Do we as providers have to establish with a payer group first, or does CHCF link after the grant approval? You may know from my previous comments, you need to come to the table with a partnership already committed. You may not have worked together extensively up until now, but you need to have had enough conversation about submitting the RFP that each partner feels comfortable and committed to working together during the planning grant with the intention of meeting the deliverables in the request for proposal. Let's see. Would a home health setting be considered community-based? Yes. Housing opportunities for people with AIDS. Oh, I see. Thank you so much for housing opportunities for people with AIDS. I'm not familiar with that. Don't know what their payer capacity is. So again, as I said, if you have a specific detailed question about does your payer-provider partnership qualify for the initiative, please send me some details, and I will respond to you so that you don't spend a lot of time putting a response together and then find out that it doesn't meet the qualification. So definitely do that with me first if you're concerned. So we are a hospital-based home health agency. The hospital is at risk. Are we eligible for the RFP?
Like one organization.
So if you're in a combined entity, if you're a hospital running a home health agency, again, thinking about the intent of this initiative is we're trying to link together two separate organizations into a new type of a partnership. That's what we're going for overall. Again, if you have a detailed question, please send it to me and I can respond before you know whether or not you want to invest. Another question, in our proposal, we are hoping to include 2 insurance companies, 1 hospice agency, academic medical center, more than 1 provider and 1 payer. Is this a feasible option? Well, it sounds like a lot to manage, but I wouldn't say no.
Yeah, no, I think our thoughts on 1 and 1 was that that's a great place to start. If you're in a position that your relationships with these organizations are already being established and there's a degree of comfort with multiple organizations partnering, I think it's a fine thing to propose.
Mm-hmm. Okay, moving on to the next question. Here's a question from an individual: forming a nonprofit behavioral health group. Will my new group be able to participate in this round? I don't know. It doesn't sound, if you don't already have something operating and established track record on community-based palliative care, I would say probably not. You may be watching how this develops and maybe planning for the future. Let's see, another question. We are a unique charitable grant-making foundation that supports palliative care programs in our area. Fabulous. So, though we do not assume risk per se, we are a payer. Could we be a non-traditional payer? Interesting. Why don't you send me more details of that question? I'd like to know you in any event. Let's see. Okay. A question, our current private funders are not payers as we understand it here. Can you open a web page where the payers and providers can meet and start these partnerships? Well, that's an interesting question. I always get the most interesting questions. I'm not quite sure how that would work out in the timeline that we have for this particular proposal, given that we want to get the proposals in by August. Not sure how these connections would take place. We're really hoping that people will come into the RFP with a provider already identified.
I'd also mention that a government funder is okay. It doesn't have to be a private insurance company.
Right.
So,
if you can
get keep in mind.
Yeah, if you can get a government funder to read the RFP and want to partner with you, then that would be fine. Okay. We have some very detailed questions and some phone questions. Oh, good Lord. Okay, so shall we read this one? Transitional housing program for homeless women with significant medical challenges, including cancer. Developed a hospice program with a partnership of local hospices, outside hospice service to enable women to stay home with us through final transition. Is there a place in the proposal to provide this kind of palliative hospice care for homeless individuals? If you have a service plan and you are a provider, then the missing piece for you then is to find your payer partner who wants to assume that responsibility in this RFP, the planning part of the RFP.
And I would also say that, as Kate described earlier, with community-based palliative care, we are talking about pre-hospice palliative care services. So a hospice can provide it, but it has to be distinct from traditional hospice services. So we're talking about pre-hospice community-based palliative care. And I can't tell from that message whether you provide that or only hospice care.
Okay, another question, is telehealth as a modality for enhancing home palliative care something that would be considered? Sure, but only if you're already providing community-based palliative care. So a telehealth program as a standalone wouldn't really substitute for an interdisciplinary team-based care providing entity. But if it's an augmentation of a service, I think that that would be very interesting. Okay. Is this proposal open to care of homeless individuals with chronic and advanced illness where shelter is part of the equation? Yes.
If they're providing
palliative care. If you have palliative care in the mix and you have a payer, and similar to the answer we gave for skilled nursing facilities, if that's the community in which they are dwelling, then that would meet that criteria. Okay, and then a comment. While it may not work to match make before the RFP, please consider a convening for that purpose during the run of the program. Interesting? Yeah, something to consider. Thank you. Can you reiterate what you said about a risk provider group as a few minutes ago? Could you imagine a partnership between a risk hospital and an affiliated medical foundation? Risk hospital, an at-risk hospital, and an affiliated medical foundation. I would recommend that you send me that question to my email with a little bit more detail, and that would be very helpful. So, yeah, send that question to me before you invest a lot, and I will let you know. And then a question, will you be making the slides available to us?
Yeah, a recording of the webinar will be available. We could also send the slides if someone wants them separately from the webinar. So I think for that, again, email Kate, and you can forward them to me, Kate.
Yeah, okay. And then in hearkening back to the question about a risk provider group and an at-risk hospital, if this addresses your question, if the health system is an at-risk entity and you're paying a medical group to provide services, then the answer would be yes, that partnership would qualify, unless they're within the same organization. So again, keeping in mind the intent of this is to bring together, for this particular, this isn't the only way to do this, but for this initiative, the way we have structured it, we're looking to bring together payers and organizations, provider groups, to create a way to provide and enhance access to community-based palliative care services. So I realize the payer landscape and the provider landscape is very complex, and if you have a specific question, without repeating myself to death, please send it to me before you invest in responding to the RFP. And if I don't know the answer, I will secure the answer for you within our planning group to make sure that everyone who's eligible knows they're eligible, and then they can pursue whether or not they want to pursue. Here's a question. We are planning to implement but do not currently provide community-based palliative care, but have extensive experience in hospital-based palliative care. Would we qualify as an eligible provider partner? I would say not at this time. Okay.
Now we can, I think at this time we're going to move to individually unmute some lines for people who have raised their hands with a question. That was that one.
Oh, okay.
So
I think we've answered a lot. Maybe not this one.
We'll see if when we call on you, if we've already read your question through the chat, because you might have done both. So the first person we're going to unmute the line for to see if you still have a question is Mindy Danavero from Sutter, Auburn. Click on the red.
Okay.
Hold on one moment.
And Brenda, I saw your question. We will get back to you. I'll answer you privately. Okay, so Mindy. Are you on the line?
Yes, I am. Can you hear me?
Yes, we can.
Okay. Just for ease of contacting you, could you repeat your email address so we have the place to send our questions, our individual questions?
Certainly. It's Kate O'Malley, and my email address is KO, M as in Mary, ALLEY at CHCF as in Frank, CHCF.org. So that's where you can send me all of your detailed questions about what partnerships would qualify.
Perfect. Thank you very much.
Thank you, Mindy.
Okay, so the next person we're going to unmute or have unmuted for a question is David Steinhorn, if you still have a question.
No, I'm good.
Okay. Thank you.
We can remute.
Okay.
Click it again. And, okay, we'll see, I can't see the last name, but there's
Vincent from Alpine Behavioral Health. Did we answer your question?
Is there a Vincent from Alpine Behavioral Health still on the line? We just unmuted your line.
I think we did answer the question, maybe?
Oh, my gosh.
Oh, I see.
Okay, well, not on the line right now. So
Okay.
We'll mute you again.
And then Ann.
I think we got Ann Kinderman, but we can check back in. We'll unmute you, Ann, for a moment. Was your question just about the community-based, not yet providing community-based palliative care? Not on the line anymore.
Okay. All right, great.
Mute her again.
Okay, so let's see. I think we have got through all the chat questions, and we have all the people. Oops, we have one more. So Jeanette.
Jeanette from Grandma's House of Hope, we've just unmuted your line. Do you have another question?
Yeah, I was going back to the idea of more than one payer. So we currently work with a lot of different hospitals who call us directly when they have clients who typically would be refused care if they didn't have a place to live. So on the question before about the homeless provider, so we're the only provider for women with breast cancer who are homeless in Orange County at this time. that provides shelter services, housing services, as well as all that support. But we do get referrals and connect with several different payers for that, being some nonprofit agencies and also the hospitals themselves who place clients with us for several months at a time. So would we want to pick like the one we work with the most and try to drill down just with that one partner, or is it helpful to list the additional partners that we work with?
I guess the question is the degree to which you're providing community-based palliative care the way that we've described it.
Right. So
do you have, versus housing and support. So if you have a physician, nurse, social worker, chaplain with experience in palliative care, working with your residents on pain and symptom management, goals of care, spiritual support, family support, emotional support, and providing the spectrum of palliative care services, then that's really what we're after in this particular initiative. I mean, we understand there's lots of excellent providers in California doing wonderful things who should be reimbursed, and I think the intention of this work is focused really on a full spectrum of palliative care services in a community setting and finding a payer who can support that.
Right. So it sounds like everything you listed we do directly on site other than having a staff doctor. So we provide the connection and the access to, we connect and co-case manage with their doctor and medical provider care. But as far as, in the home, we're providing all of the rest of what you said without a doctor on site.
Mm-hmm. Well, if you want to apply, I wouldn't discourage you. If you want to send me an email with more description about what your payer source is going to be and the direction that you're going in, I'd be happy to talk it over with our team and make sure we're not encouraging you falsely to apply. So anyone can apply to a request for proposal, so we don't want to discourage anyone. But we just want to make it clear what the combination we're looking for and what the intent is, so that you can sort of think through, do you have the services required that are actually functioning in the community, and do you have a reliable payer who is going to support those services?
Right. Okay. All right. Well, thank you. I think I will send you an email.
Okay, great. Thanks, Jeanette.
All right.
Okay, and then we have, please clarify that a hospital can be a lead applicant if the setting is community-based.
If your question means that the hospital provides community-based palliative care, then yes, the hospital can be the provider applicant.
Yes.
I think that's what your question means.
Yes, if it is.
Right. Okay. She just responded yes.
Yeah, so perfect.
Okay. Here's another question.
Please further clarify the definition of payer partner. So what we are looking for here, the most obvious payer partner is a health insurer, but we didn't want to limit our request for proposals only to partnerships with health insurers. So if you have, let's say, for example, the Medi-Cal program in the state of California, who pays for who pays for services, then that would be classified as a payer. So another way you can look at this is an entity that is at risk for healthcare expenditures can be your payer partner. Thank you, Kathleen.
So are there any other questions that folks would like to either ask by phone? If you want to do that, you use the raise your hand function. I think we're a big enough group that we shouldn't unmute all the lines.
Yeah.
And the raise your hand seems to be working. We'll see if there are any more of those. These are the ones we've already done. Or any other questions that anyone would like to send in. Oh, we have one new hand raised. Okay, so we're going to unmute the line. Oops, if I can. He does not appear to be on the phone anymore.
Oh, okay.
It looks like Marvin Gordon.
Dr. Gordon from HealthNet
may have raised a hand, but it's not looking like you're. You may have dialed in using a phone number instead of having the system call you back, so it's not recognizing which user you are for us to unmute your line. So Marvin Gordon, Dr. Gordon from HealthNet, if you could type your question into the chat, we can respond that way because we can't tell which phone line is yours. We'll give a few moments to do that, or a few moments for anyone else to type any questions into the chat or potentially raise your hand. Let's see. So far, I'm not seeing any other hands being raised or any new questions coming in. Oh, here we have one more question. So I'll wait till Kate is just responding privately to another question.
Sorry about that.
That's
distracted.
Right. We're multitasking.
We're multitasking.
Trying to answer as many questions as we can. We'll do send for that.
Okay. So what percentage of the planning grantees do you anticipate funding for an implementation program in the future? Well, that's a great question. I don't know the answer because we don't know what we'll get for requests for the proposal, and of the 10, up to 10 that move forward, the strength of their proposals that we would feel comfortable bringing forward to the board for additional funding. So I can say optimistically, best case scenario, up to 10. But it's probably less than that. I would say maybe 7 to 8. So, yeah. Oh, here's one question. Are financial arrangements between the parties kept confidential? I have no reason to see why we would not keep them confidential. We would just, let's see, if they wanted to do, if they're submitting a plan, would we want to see the plan?
What does confidential mean with CHCF?
Yeah, I guess it means what's your definition of confidential? If you mean just within this particular feasibility assessment, yes. There's no reason the foundation would have to make those arrangements to make them public. So as long as we could see them and get a sense of what they were and how viable we thought they were, there would be no reason for us to make them, to not keep them confidential.
I'll add to that, I think, in terms of helping to use the learnings from this work to apply more broadly to provider-payer partnerships, I think we would want to know the sort of general parameters of an agreement between a payer and provider in terms of how providers are being reimbursed for their work, but we wouldn't need to know specific dollars.
Yeah,
if that's what the question is. We
right.
kind of want to know the construct, but we wouldn't need to publicize specific dollars.
Right. We would not publicize. We would need to know basically what you're doing. So from our own awareness and that of our financial consultants, does this look like a viable program? I guess that's the screen that we would provide.
Okay, a few more questions have come in.
Can you repeat the list of community-based palliative care services?
I think that's when you were just saying pain and symptom management.
Oh, right. So these are, what does a palliative care team do in the community and how is it formed? So these are organized services, obviously see patients, identify needs, make treatment recommendations, facilitate patient or family decision-making, goals of care conversation, directly provide palliative care to patients with serious illness and their families. Most palliative care is provided by an interdisciplinary team of specially trained healthcare professionals who work together to address patients' physical, emotional, social, spiritual needs. So physician, nurse practitioner, nurse, social worker, chaplain. And these are your standard definitions. You can use the CAPC definition. There's also very nice definitions in the payer-provider partnerships document that I mentioned to you, the Palliative Care Toolkit and Resource Guide that CAPC put together with the National Business Group on Health. I highly recommend that. Another question, since pre-hospice services are not usually covered in the SNF and the SNF absorbs the cost, would it qualify as a payer? No, we're looking to bring together two distinct entities. So for a replicable program, you might possibly find one skilled nursing facility that might want to do this, but I don't think as an industry-wide type of a model that could be replicated, it's something that other nursing facilities might want to take on. So it's really bringing a payer distinct and separate from the service providing entity. Another question, what dollar amount might the foundation consider investing in the implemented programs in the future? Past the planning stage, would the foundation be a permanent part of the program? Permanent part. I mean, would we consider funding indefinitely? Generally, no. We're looking for self-sustaining entities for future growth. The dollar amount, it would really depend on what kind of support is required to make the implementation plans real. So what we're really looking to find is a payer that will cover the cost of an interdisciplinary team in the field, right? That's what's one of the major things that's lacking in the spread of community-based palliative care. So in past programs that are implementation funded, sometimes the foundation will put into place staff support dollars with the intention that the program gets picked up and maintained and sustained over a period of time. So I can't tell you now really any dollar amount that we might consider in the future because we don't know what the plans are going to look like and what will it take to launch these kinds of plans. But that is something that at the end of this planning period, we will work with our advisors and the faculty on this project. We would look at all the feasibility plans that come in, and we would get a sense of what it will take to stand these up and actually make them functional in the field. And that will guide some of the decisions about what kind of investment we might make. Okay. And I think, did we get everybody? Okay. I think we did. I don't see any other hands raised. I don't see any other chat. We're scrolling down one more time. That's it. That seems to be it. Well, I guess that's the end of our time here today in terms of questions and comments. Thank you very, very much for your time, and thank you so much for the interest in this initiative. As I mentioned, if you have specific questions about whether or not you qualify to submit a response to the request for proposal, please send me a detail of your partnership to ko'malley@chcf.org, and I will respond to you so that you can invest your time wisely. And that's all I have. And Kate Myers?
And I think what we'll try to do is to, if possible, make the link to this webinar available on the CHCF website where we have the RFP information so that you are able to get back to that link if you'd like to look at it, as well as the slides from this webinar.
Yes. So check into the
posted within a couple days.
Yeah. So the same site that you hopefully went to find out information about this request for proposals is on the foundation website, and we will post a link to the webinar and the slides on that location within a couple days. Just repeating what you said. It was brilliant.
Perfect. All right.
All right.
Thanks so much, everyone.
Thanks, everyone. Bye-bye.